Hey guys, can you hear me? See me? Hello guys, how are you doing? Am I audible, visible? Hello everyone. A very good evening guys. Hope I'm audible and visible. And if you guys are online, just put a hi and a hello and let's start without any delay. So welcome back. So we have started the FARRE. Hello Ash. Hope I'm audible and visible. So I'll be starting with systemic pathology because the reason is I'm sure whenever you started revision, you must have started from general pathology and you must have revised general pathology to a decent amount. You must have read it again and again. And where the revision falls off is in starting from hemat and systemic path, right? So we'll go in the reverse order. We'll start systemic pathology, we'll complete hematology, then we'll go to general pathology, right? So good evening, everyone. So FARRE is going to be just a final touch to compile all the information and also how to kind of make a structure to the question. That's all. We have already read things and we're just going to redo it here, right? Hi Khalib, hello everyone. Hi. Okay, so you have in a university exam, you have LAQ, right? You have short answers and you have one liners or MCQs, right? So this is how the predominant thing is. Some of them might have two, some of them might have three. Hello, very random. Hello everyone. So here the LAQ has to be presented in a way that it appeals for an examiner so that we can look at the data points and say, okay, this student has thought through very well and come to a diagnosis. Please remember one thing, LAQ, the most important thing is not the right diagnosis, though obviously you'll be very happy and give more marks when you write the right diagnosis. But if your approach is normal and maybe you miss a little bit, or let's say if you use the term differential diagnosis and give two options, you're not going to say it's wrong, right? So don't be demotivated in exam after writing something, coming back and your friend said this is not the right answer, right? So please don't be in that motive. We'll write how to structure it and then we'll come to a diagnosis or a differential diagnosis and let's see how to go with that, right? And in short answer format, what you're going to do is, let's say in renal pathology, which you're going to discuss today, glomerular nephritis is definitely a possible, like minimal changes can come in a short note. What are the headings which are important? This is with respect to renal pathology. So we're going to have pure templates. So I'm just going to fill the templates with the existing knowledge. I want you to redo it. And if possible, if you guys are interactive, that will be great. If you can answer me when I ask a question, it's like a revision because your exam is not far away, right? Okay. Anish, we'll see how to structure it so that your marks will not fall off, fine? Okay. So with that note, this is how I want you to present the long answer format. Any LAQ with respect to pathology, use this. If this format fits in for an microbiology, also do that. Pharmacology might not. If it fits, do that. ENT, ophthalm, medicine search, if it fits, do that as well, right? So first thing and the foremost thing is, don't jump to the diagnosis. Because let's say there's a question on thalassemia. You know it's thalassemia. I don't want to write diagnosis beta thalassemia. I won't know what you thought of, right? So let's say I'm just randomly discussing a case of thalassemia, though we are not going to discuss RBC today. Let's say we are going to have a clinical history of thalassemia major, fine. So what I want you to write is, don't just write diagnosis thalassemia, right? First I want you to say, okay, the age is an important clue here. 2-year-old kid presenting with very severe anemia. So that is an important point here. Maybe x-ray finding, you had an hair on end appearance. See, all these are not extra effort. You are taking from the questions. Write it there. And then on a peripheral smear, there might be multiple information in peripheral smear, target cells. And HPLC, there might be again multiple information, but elevated HbA2. Because of all these information, I know the diagnosis. If you know the exact diagnosis, write the diagnosis. If you want to write differential diagnosis, give a DD of severe hemolytic anemia. Fine. Okay. So write, okay, I'm going to think of beta thalassemia major. So this half a page of your LAQ has no effort. You are taking the information right from the question. You're just writing in a way that a normal doctor will think about it and write here. Fine. Okay. Vidushi, teardrop cells will not be here, right? Okay, yeah. See, Snehajit, coming to your question, if the first part or A of the long answer is what is your provisional diagnosis, there also I want you to write the same way. I know it's a provisional diagnosis, but how did I come to a provisional diagnosis? Why should I give you 4 marks just for a word of beta thalassemia major? I will not, right? So take the same question, break it down and tell to the examiner why you came to this diagnosis. That will make a very solid point for you to start with. It gives an impression. In your 12th standard, 11th standard school days, you may say, let's synopsis for an essay, no? This is where it starts with. So if you write like this, it will be good, right? With this, you won't have teardrop cells. If there's teardrop cells on peripheral smear, I would think of a myelofibrosis, fine? Okay, so that's what I'm trying to make here. This gives a structure to your knowledge. So anytime any person reads it, they will know that he or she has known what they are, why did they write as a diagnosis. I didn't copy from someone else. It's not a guesswork. I had a systematic approach, right? Anything, any question, if it's a clinical scenario, write like this. It's a shock, fine. There's an etiology of trauma, heavy blood loss, thready pulse, so a shock. Okay. Okay, Ipshita, why do I want to put differential diagnosis? Let's say you know it's a leukemia, but you don't have an exact information like an OR rod or TDT positive, say acute myeloid or acute lymphoid. So write leukemia. Probably because of the age, I think of an acute myeloid leukemia. Fine. Okay. So that's why I want differential diagnosis. If you're not very sure about the diagnosis, use the term differential diagnosis. If you're sure about the diagnosis, use the term most probable diagnosis. Clear? Okay. Hi, Rishan. So if you're clear with this, I want to start with LAQ scenarios in renal pathology. I want 5 people to say yes, only then I'm going to go to the scenario. I will show you the scenario, the clinical stem, and I want you to tell what are the important points you will write in the clinical stem in the answer. Then we'll see how to present. I have 3-4 scenarios which will cover most of the LAQs with respect to clinical renal pathology. Then what we'll do is we'll see what to write in the part B of the question. The etiology, the pathogenesis, morphogenesis of an LAQ. Fine? Ready? Come on, 5 S's should be okay, right? Amazing, right? Anshu is the first person that's given a long S. Okay, so let's go through. This is the first question. I want all of you guys to read the question. It's not the fastest finger first. Okay. Yes, Anish. Differential diagnosis, probably like if it's fever history, dengue can be there, malaria can be there. That's a differential diagnosis. Fine. Okay. Ashley the Medico, differential diagnosis gives an information on if I'm not sure about one diagnosis, write it. Okay. Hi, Aniket. So tell me, what are the important key points here? If there are important key points in the data, what all you will write? So that we get used to what should be there in the exam paper. What's a diagnosis, first of all? Anju, I know it's ADPKD, right? Everyone will jump to ADPKD. Like I said, I don't want ADPKD. Everyone knows it is ADPKD. I want you to write the data points which will lead to ADPKD. First, I would say an elderly person. Okay, 45-year-old person having an early onset. See, I'm taking the same data points because 45-year-old elderly person presenting with early onset hypertension, I will think of a renal pathology, right? Okay, so early onset hypertension being the clinical scenario, and also I had hematuria. Hematuria, if you can answer why, probably due to renal calculi. Because in ADPKD, renal calculi formation is pretty common, right? You can also add on to it, right? Plus bilaterality. Okay, it's bilateral, so something may be congenital. If it's a unilateral problem, most likely acquired. And the final thing is USG shows multiple cysts, right? So finally, what I would say is based on the age, the symptom, and the final conclusive ultrasonogram finding, I would probably think of an ADPKD, right? So I have to present in a way. I know it's ADPKD, you know it's ADPKD, but I have to tell to the examiner why I thought of ADPKD, right? So if let's say the key gives nephronophthisis, but still it could be nephronophthisis, but clinically it's comfortable to call it an ADPKD, right? So age, elderly, history of hypertension, bilateral, hematuria probably due to renal stones, bilateral cyst formation in ultrasonogram. So my most probable diagnosis, an autosomal dominant polycystic kidney disease. So this gives the first 4-5 lines of your long answer question very, very concrete and very, very solid. Because in an university exam, the reason I'm not getting good marks is I know the knowledge, I have the concept, I have the knowledge, but I'm not getting good marks. If you're in that group, you're not presenting it properly. Handwriting, legible handwriting is enough. Neat handwriting is not required at all, right? A legible handwriting, if I can give bullet points, I can structure properly, that should be enough, right? So let's go to the second question. I know you know the answer. I don't want the answer. I just want the important history or the important data points in the question. That's all. Okay. Tell me what it could be. What do you think will present here? I want the data points. I know you know the answer. Answer is pretty simple here. Answer is not difficult here. A 3-year-old kid, okay, that's something. And presenting with an abdomen distension and failure to thrive. Okay. That's an important finding. Clinical examination shows few important things, and there are cysts in the kidney, right? Perfect. See, all these are important points for me. Actually, there are more informations other than ARPKD here. Can I say this patient might also have a liver problem? How many of you think there might be a liver problem associated in this patient? You guys are exactly right. This is what I want you to write, right? Child, early onset, enlarged kidney. But what you missed is the liver point, right? I want you to add that also. Liver enlargement, probably there are liver cyst or associated liver failure, because liver failure association can also add on to the abdomen swelling in addition to the renal failure, right? So could be an hepatomegaly, could be an association there, because liver can also have cyst or a fibrosis, congenital hepatic fibrosis in an ARPKD, young age, investigation showing cyst. So my most probable diagnosis is ARPKD. Use this term. These terms are legal terminologies. This is how your consultants would write the diagnosis, most probable diagnosis. No one will be like, I know this is the answer. Case sheet will always be written most probable diagnosis. The terms most probable diagnosis helps. Okay, you're thinking like a doctor. You're not a student anymore, right? You're completing second year. For me, you're my colleague, right? So I want you to think in terms of a doctor thinks, a practicing doctor, and also write in terms of how a practicing doctor thinks, right? Rishank, you're absolutely right. I can also have hepatomegaly in ADPKD, but I won't have ADPKD at 3-year-old. That's why age is important for me. Age, failure of the kidney, liver having a problem, cyst in the kidney. So my probable diagnosis, including the age, is ARPKD, right? This is why, Rishank, my approach is important. Because you said ADPKD can happen, it can happen. I'm not denying that. But this approach helps me saying that, okay, the student has thought through, ruled out ADPKD and wrote ARPKD. I'll make a very good first impression, even if I make some wrong points in the second part of the question. Like, okay, first impression always good, right? It'll get you more marks, fine? Okay, next. I want again just the approach, what you're going to write. Then we'll discuss about the disease as well. Sure, Anish. Not as of now. When you come to practice, we'll take care of that. Great, Arman. Snehjit, I know you know that's RCC. I want the approach, right? Approach is old age. I know everyone knows it's a renal cell carcinoma. I'm not asking about that at all. Yes, you know it's smoking. Spam. Good evening, but please change your name. Smoking is there. Anything else? Weight loss, hematuria. Perfect. See, what Sheetal told was perfect, linking to the textbook. A triad of pain, mass, and hematuria. That's a classical triad explained in terms of a renal cell carcinoma, right? Okay. So what I want here is elderly smoker, etiology taken care of it, right? Hematuria, weight loss, pain. Mostly weight loss, mostly in a cancer. This is a classical triad of RCC, right? A triad of an hematuria, abdomen mass, and pain is a classical triad of an RCC, and investigation shows a solid renal mass. Anything solid, you know the desmoplasia, everything can happen. So my most probable diagnosis, renal cell carcinoma. Please don't be overconfident and write clear cell type. That is inviting trouble. Because I'm having a clinical diagnosis. You can justify by saying that's the most common type, but this amount of specific answer I don't want. Fine. Okay. Rishank, pain in RCC can be due to multiple things. It's going to be an expanding mass. It can stretch the capsule. It can be anything, right? Or it's going to invade to the adjacent structures. Okay. Perfect. Rishank, I just wanted to say that don't commit that is a clear cell type, because clinically I can only say it's the most common type. So I think of that. Renal cell carcinoma with this question is very good. If they ask in the second part of the question, explain about the most common type or explain about every other possibility, then write about it. Fine. Okay. How kind of inviting trouble is Nejit? How did you say it's clear cell renal cell carcinoma except for the incidence? I can't, right? Because Your chromophobe RCC also will have the same triad. Papillary RCC will also have the same triad, right? So that's why I'm saying renal cell carcinoma itself is an amazing diagnosis for a second year. Just because I want a gold medal or a honors, that's like kind of inviting them. Maybe you can write, since most common causes clear cell RCC, I would think of that. But don't jump into saying clear cell RCC. Because you must have read in your microbiology, dengue fever is breakbone fever. It'll have fever with joint pain. But there are n number of differential diagnoses of fever with joint pain. If I say viral fever, I'm safe. Dengue fever, I'm not a bit safe because there might be a pointers I can disapprove that. That's what, fine. Okay. So I need a microscopy to say it's clear cell carcinoma. Snejit, yes, I can, but it's not a fight between you and the examiner, right? Let the examiner be great. That's how it is, fine. Okay. Next one. Same data points. What do you think? How do you write? And how do you come to a diagnosis? A 12-year-old boy, dark cola colored urine, periorbital puffiness, recent onset hypertension, a sore throat 2 weeks ago. It's a very simple diagnosis, PSGN, not just due to cola colored urine. Cola colored urine tells me it's nephritic syndrome. It does not say PSGN, right? Let's see how many of you give me the exact data points what I'm looking for. The most important point which I'm looking for is this term. Because hematuria, hypertension will say it's nephritic syndrome. Sore throat, can it be a possibility in IgA nephropathy also? Yes. IgA nephropathy is also nephritic syndrome, right? Cola colored urine and sore throat does not make it PSGN. The past history after 2 weeks having hematuria makes it a PSGN, right? So the past history is more important here. Sore throat alone is not important here. Past history of sore throat and after 2 weeks having the current presentation of hematuria makes it PSGN. If let's say it's 2 days ago, what will be answer? It cannot be PSGN, right? 2 days back, I had a sore throat. Now there's an hematuria. My entire diagnosis will be IgA nephropathy. So these are things which I'm looking for, right? So you know what is PSGN, you know what is nephritic syndrome, you know its presence with hypertension and hematuria, you know sore throat is involved, but what is important is this history. So the first thing is past history. Past history of sore throat 2 weeks back and now presenting, it's a nephritic syndrome, probably PSGN or PIGN. Fine. Okay. So that's very, very important how you present. If you present like this, first half is sorted, second half automatically will get marks, right? So what you're going to do in second half is just one more question, then we'll go how to present the second half of the LAQ. Last one. Yes, Raghu, it will be tricky, right? Obviously, you have to be very careful in reading the question because that leads to the answer. It might change the entire answer. It's not difficult. Tell me the diagnosis. RPGN. Okay. A patient with an congestive heart failure presents with rapid decline in urine output, fatigue, and confusion. Blood test shows elevated creatinine, blood urea nitrogen, indicating an acute kidney injury. Great, Satvik, right? So what I'm going to think of is here, I have an history of cardiac failure. So I can easily explain there'll be an reduced cardiac output. Because of reduced cardiac output, I might have less blood supply to the kidney, or I might have, in other words, ischemia to the kidney. So if you have ischemia to the kidney, right, that will obviously result in hypoxia and everything, which can cause an acute tubular injury or an ischemic ATN. That is explained by my lab findings, right? Perfect. Like Ashley said, it's exactly a pre-renal acute kidney injury due to hypoxia or due to ischemia here, right? That explains my lab findings. Increased blood urea nitrogen, creatinine. Why didn't I say it's RPGN? To tell me it's RPGN, I need a history of rapid progression. Today it is 1 milligram, tomorrow it is 8 milligram. That is rapid progression. But here the only problem here is cardiac failure. The patient didn't have any kidney disease. Rapidly progressive glomerulonephritis happens on a pre-existing kidney disease, right? So the most probable diagnosis, you can write ATN or an ischemic acute kidney injury or an ischemic ATN. That should be more than enough. Fine. Okay. So it's just an acute kidney injury due to ischemia. The ischemia is predisposed due to hypoxia or reduced blood supply due to cardiac failure. Fine. It's completely fair, right? So please remember, for everyone who said RPGN, I'll write here, why not RPGN? Two things. RPGN happens on existing renal problem, existing glomerulonephritis, and there should be a progression from 2 milligram. These are just for examples, become 7 or 8 milligram percentage within 24 or 48 hours. If I have this progression, I can call it an RPGN, not from zero. RPGN always happens on pre-existing renal disease only. PSGN can become RPGN. IgA can become RPGN. Not normal cannot become RPGN, right? Old case of a good pasture can become RPGN, right? Pre-existing kidney disease, progressing, it's RPGN. Otherwise, it's not RPGN. Fine, clear? So this should take care of most of the things in your first half of an LAQ. This is how we are going to structure every exam, every chapter, few clinical scenarios which can come in the first half of the LAQ. Second is short notes. Short note format will actually fit to the second half of a LAQ. Let's say I have a question on PSGN. What will be the second half? Write the ATO pathogenesis, microscopy, and probable treatment for the above disease. That's how they'll ask. If the LAQ is about CML, they'll write about the pathogenesis, the chromosomal changes, microscopy, and investigation of choice, right? Okay. Answer is actually it is ischemic ATN or an ischemic AKI, right? So second half of a LAQ and short answer is almost the same. What will I ask in short answer? Write short notes on minimal chain disease. Write short notes on RPGN. That's how we're going to ask a short answer, right? So this short answer format is only for renal pathology. Let's create short answer format similarly for every chapter. So that I just want to make sure you write all this. If you write all this, that's more than enough for me. Headings are very important. So now I know if I write at least one line or 2 points for every heading here, that will make sure almost everything will be covered, right? Okay. We'll cover it. That's what is management, right, Snejit? The follow-up is the management where we'll cover about the follow-up, fine? Okay. Spam this for second prof students who are going for the exam, not much, fine? So management and complication, we'll include that part so that if at all it comes in LAQ, we can include that as well, fine? Okay. So for clinical features, always have a template. When I mean a template, you take kidney, I can have only these 4 templates, right? Nephritic, nephrotic, acute, chronic. Right? Now, can you ping me later? I'll explain that, fine? Like if I go for a liver failure, I can have acute liver injury, chronic liver injury, right? If you go for cardiac, acute complication, chronic complication, MI. So I have sets of clinical features. Remember them. Keep a note and write these are the probable clinical features which can come. So that I need not go and remember every time a clinical feature. Let's say I'm taking an acute kidney injury. I'll write whatever is going to be there here. Let's say I'm having a patient with an IgA nephropathy. I'll write whatever will be the nephritic syndrome. Let's say I'm having a question on membranous glomerulonephritis. I'll write whatever is there in nephrotic syndrome. So for me, remember this. If you go to Robbins, most of the Robbins starting point, there'll be a table. If you go to kidney, this will be the table. So if I say it's a question on nephritic syndrome, all these can fit into the clinical features and lab investigation. I need not remember again and again. I'll just know it's nephritic syndrome. That's enough for me. I'll automatically take and write these points. If I know it's an RPGN, acute nephritis, proteinuria, acute renal failure, and like I said, a rapid progression. So rapid progression from a pre-existing disease tells it means it's an RPGN. So any question which is asked on RPGN, this is how my clinical presentation will be. I already know what to write, right? Any question on nephrotic syndrome, it could be an FSGS. It could be your IgN, it could be your minimal chain disease. It could be a membranous glomerulonephritis. Any nephrotic syndrome, this will be the same, right? More than 3.5 grams per deciliter, massive selective proteinuria. Along with that, you have your facial puffiness, classical symptoms, right? Along with that, I can have a symptom of facial puffiness or your periorbital puffiness. That will help me. Okay, these are the points I can write. So I already know 2-3 lines for every clinical manifestation. Whatever question which comes there, I know 2-3 lines, right? It's a CKD. I can write uremia progressing from months to year. Azotemia is your altered blood urea nitrogen, right? Acute renal failure, loss of urine output, azotemia. Azotemia means I'm going to have an increased blood urea nitrogen and elevated creatinine. It's renal failure, that's all, right? So this I want you to write. Keep a note to tabulate every clinical feature, 4-5 permutation combinations for every organ system. What will maximum happen in RBC disorder? Hemolytic anemia, extravascular, intravascular, that's all. Fatigue, pallor, common for everything. Splenomegaly, extravascular. Hematuria, intravascular. Done. Write it, that's all. Lymphoma, leukemia, what will happen? Every lymphoma is generalized lymphadenopathy. Might have hepatosplenomegaly, plus or minus. Leukemia, bleeding gums, common. It's pancytopenia, right? You'll have anemia, you'll have fatigue, you'll have recurrent fever. So that's how I can take it, fine? You can definitely write here, I can have a reduced GFR also. In the lab investigation, you can write negatives, right? So create templates like this. I'll give you templates for every system. These are the 4-5 things I want you to remember. 90% of the question will fit into this template, fine? Actually, it's the chronicity. That's one thing. Similar symptom progression, the only thing is RPGN has a progression. The progression is thing because RPGN is an example of an acute renal failure. It will have the similar symptoms. Fine. So we'll do this for every system. So you'll have a like 7-8 systems template. Whatever question comes, you know what to write for clinical manifestation. Fine. We'll look into its nature. We won't mess it up. I'll have for every chapter boxes like this. Just take this box, keep it there so that I'll compile the box later on and give it to you also. At final go, you know all the clinical symptoms what to write, right? Now what we're going to do is, you are going to help me to fill this up for every disease which is there in the kidney. Are you guys ready? You're going to tell me 1-2 words of etiopathogenesis. I don't want the entire thing. This is exam. It's not to prove that you are knowledgeable. It's to convey that you are knowledgeable. That's two different things. Right? I have to just tell to the examiner, okay, this guy or girl knows the subject, fine. 1-2 words for etiopathogenesis. Clinical feature, I don't want you to write everything. Say nephritic, nephrotic. Automatically your mind should know what to write. Tell me 1-2 findings for microscopy, 1-2 findings for immunofluorescence. See, it's template, no. Immunofluorescence will have granular linear, IgG, IgM. You can just like a drop down, that's all. Electron microscopy, subepithelial, endothelial or intramembranous. Management and complication will go into it, fine. Okay, let's go. Let's start. PSGN, PAGN. Please comment the etiopathogenesis. I want you guys to comment. If when you comment, I'll automatically go to the... I'll keep writing it along whenever you comment that. So etiopathogenesis, it's a history of an URI or a skin infection. Post that, there'll be circulating pathogen. The circulating antigen in the circulation will go and get deposited, will be the word. These words are important. Planted antigen. Because the pathogenesis, if you look in Robbins, it comes under the planted antigen, right? The planted antigen, perfect, right? The planted antigen will elicit immune response. The immune response, if you want to little bit elaborate the immune response, write IgG plus complements, because complements I want you to write, because low complements is very, very important for me as a diagnostic point, right? That will damage the glomeruli and that causes your hematuria, because it's a pure case of a nephritic syndrome. If you write this in a long 1 by 1 by 1, it will take half a page. Okay, thank you. Fine. So this how I want you to remember, just important points. URI or a skin infection, planted, elicit an immune response, destroy the damage, add a thing. If you write vertically, you can write that, use different color for the timeline. Minimum, actually, let's go as per the textbook, 1 to 3 weeks. The lag time is very, very important for the symptoms and the etiology. Fine. That's important. Perfect. So we know what to write in the etiopathogenesis. This will take care of most of the thing. If it's a long answer on PSGN, the first question will be on etiopathogenesis, right? Okay. Planted antigen shrink. Okay. The immune complex goes and gets planted. Go with planted antigen, that's fine. But it's also type 3 hypersensitivity only. Okay. Perfect. Now let's go to clinical features. In clinical features, it's nephritic syndrome. But the most important thing I want you to write in clinical features is two things. One, predominantly seen in children. Second, past history of sore throat. You have to emphasize on that there will be a lag time between the onset of sore throat and between the onset of hematuria. There's something which is very, very important. Do remember them, right? So children most commonly affected, and there'll be a past history. In addition to that, symptom, okay, hematuria, hypertension, mild proteinuria, whatever you want, you can add on to it, fine? Okay, Rajiv, go with the notes, fine? Okay, now let's go to microscopy. Any one point in microscopy. Microscopy is the heart of pathology, right? If you want to draw diagrams, you are good in drawing diagrams, draw diagrams. Any one point in microscopy. One, simple things. Enlarged glomeruli. This is to fill up pages. Is it useful in any sense? Not useful at all. Second, and the most important thing, I'll write important points in red, right? So you'll have endocapillary hypercellularity. This term is very, very important for me. So when I say endocapillary hypercellularity, if you want to write more, neutrophilic infiltration is what we understood, but the term is endocapillary hypercellularity, right? That's nothing but increase in WBCs, or you can write increase in neutrophils. Okay. If you want to present in the form of a diagram, draw a glomeruli. You need not be artistic. It can be simple rounds. Have pink color shades in between for the mesangium. Draw it and just put neutrophils inside that, right? See, you need not exactly draw a diagram. If you want draw a diagram, maybe write WBC in the lumen. If you want, write it. Because it's easily possible to do it. And if you're smart enough, in a single thing, write this side normal, write this side PSGN. So it's all about the presentation in exam, that's all, fine? Yeah, that's why I said it's type C, go with plantar antigen, fine? Type 3, fine? So normal is there, PSGN is there. If I have a question on FSGS, normal, shaded pink. MGN, normal, shaded thicker, that's all. You can easily show the difference in a single image itself, that's more than enough, right? Next, immunofluorescence, you have linear or granular? It is granular positivity. The most important thing is for IgG and C3. You can also write in the brackets IgM also, but IgG and C3 is more important for me. If you want to make it more looking like a book, like what Snake just said, lumpy bumpy deposits, you can add on to it. You can write that lumpy bumpy deposit if you want to stick to the book. But the most important thing, along with the immunofluorescence, also write serum C3 will be low, because that's very, very important for me. I'll have low serum C3. Okay, perfect, right? Then my electron microscopy. Electron microscopy, subepithelial deposit. But in PSGN, I look for the word subepithelial hump-like deposit. Okay, it's a deposit just in a random place, not throughout, not uniform, because it's plantar antigen, right? Subepithelial hump-like deposit, right? Now management. Since you ask for a question, most of the time people ask for follow-up and complication also in the management, right? PSGN management is most of the time symptomatic. It's a symptomatic management, and mostly it recovers. So if let's say there are 100 cases of PSGN, 80-90% of them will come back to normal within a week or so, nothing to do. Just make sure it's not going to acute renal failure, fine? Okay. Rahu, not the right time for us to explain logically, but the deposit will not be uniform, so it has to be granular, right? The only place where it comes linear is Goodpasture syndrome, because antibody against collagen is uniform, so the deposit also is uniform, fine? I can have a complication. Complication is simple. It can become, go to PSGN. PSGN you can write, there can be a crescent formation, which can account for an acute kidney injury or an acute renal failure, which is managed by dialysis. Very, very unlikely for it to become FSGS. If you want to add on more pages, write FSGS also. But these two are more than enough for me for follow-up and complication. Most of the time, PSGM will recover. If at all it goes to complication, I can have a complication of an RPGN. Okay. Complications RPGN, not the PSGN, where I can have a crescent formation and I can have a dialysis and management for that. Fine. Just single. 5-6 headings. This is more than enough for your short notes, right? If you write all this, you should, a good examiner, not very picky, should be able to give you more than 4 on 5. That should be more than enough, right? You're not looking for 5 on 5. I hope you guys don't get 100 out of 100 in any exam, right? If you get, please get out of medicine, right? Okay. Headings, presentation. I have written it very in a narrow space because I want to complete in a page, but write legibly. If your handwriting is not good, don't write lines, write flow charts. If your handwriting is good, write whatever it is, it will be presentable. Fine. Let's do the same for almost every disease. MGN. I want you guys to say the same thing, whatever comes to your mind. Great, Banu Prakash. Snehajit, if the question is of 10 marks, the initial why is the diagnosis will carry 2-3 marks, right? After that, they'll have bifurcation on, see, 10 marks, write this a little bit more elaborately. What does planted antigen means? What will happen after the antigen gets planted? It will elicit an immune response. Antibodies will come, IgM, IgG will come, complements will get activated, that will destroy. And you can draw the diagrams of complement getting activated and destroyed, right? That's the only thing. Ultimately, the stuff is only this much. Maybe if it's a 10 mark, write nephrotic syndrome in more details. Hematuria is there, hypertension is there, right? It's just in more details, that's it. Fine. Okay. Perfect. Now let's go to membranous glomerulonephritis. It's the stuff is the same. You at one point of time in your career, you will know how to complete a question within 5 minutes. At the same time, how to talk for 10 hours about fever. You have to just elaborate, right? You will write PSM exams. After that, you'll know how to elaborate it. Okay. Perfect. Let's start this. So I have here primary, secondary. Primary is the most common, which is like Epstein said, antibodies against PLA2R. See, I am writing PLA2R. In an exam, please use the full forms. Phospholipase A2 receptor. That makes much more sense, right? Secondary could be secondary to hepatitis. It can be due to SLE. It can be due to drugs, gold. It can be due to secondary to cancers. That's very less in number. Primary is like 85 to 90% of them. That's my etiology, right? So when I go to pathogenesis, I'm going to look at the pathogenesis of primary MGN only, right? So I have IgG antibody against PLA2R receptor. That PLA2R receptor is on the surface of the glomerulus. So it will cause a type 2 hypersensitive reaction. When I say type 2 hypersensitive reaction, on a surface, that's going to destroy the glomerulus. Primarily destroys the food process because the PLA2R receptor is on the food process. That actually results in the nephrotic syndrome. Okay. If you want to elaborate, you can elaborate going back to the type 2 hypersensitivity. We have general pathology knowledge. I'm just going to take a little bit of it. If I want for a long answer, I write more of it. That's all. Fine. Clinical features is nephrotic syndrome. Here, age is not a person. Middle-age disease. Which one, Rishan? A middle-aged person. Gender is not a probability here. Nephrotic syndrome, elaborated. Might have a puffiness surface, might have massive selective proteinuria, might have lipiduria. Many things can happen, right? You can elaborate it, fine? Microscopy. Tell me what are the points which comes to microscopy. Stage is linear or granular? I just told when someone asked me that there's only one disease which can be linear. That's not this, right? Microscopy, I'll have thick glomerular capillary loops. It'll be thick like a membrane. That's why I use the term membranous glomerulonephritis, right? So again, drawing is very simple. Draw few things tiny, put a line and make it thicker. Please make sure you draw thick capillary loops. Don't completely shade it. If you completely shade it, it might look like an obliterated capillary like a KW nodule or FSGS, right? It has to be thick capillary loop, right? So that you can write here normal and you can write MGN with thick capillary loop. Right? Perfect. Okay, Sneha. So I have 1 point ready for me, right? Second thing is in silver stain, because it's also an important point, though it doesn't help in diagnosis. I can have a what appearance in silver stain? You have a spike and dome appearance. That will help me to identify, okay, it's most likely in membranous glomerulonephritis. Because the thick capillary loop is also seen in Goodpasture syndrome, right? Diffuse capillary wall thickening is seen there. So for that, I need immunofluorescence. Here, I'll have same granular positivity for immunoglobulin G. That is my go-to thing. Again, you have to also write where it is granular positive along the capillary wall. Along the capillary wall, I'll have granular positivity. That is for your case of immunofluorescence. Can anyone tell me what will be the electron microscopy? Management follow Beltel. Management primarily, since predominant of them are autoantibody formation or autoimmune formation, I need immunosuppressants. Okay. So that's the first line of management. Could be steroids, could be cyclophosphamide. You know many things about immunosuppressants by this time, right? The best thing about second year is you know quite a few drugs you can add on to the management. By the time you must have completed the pharmacology as well, right? In addition to that, I can write obviously treat the secondary cause. So wherever there's a secondary cause, always write this. This can be applied universal. Fine. Okay. Thank you, Bhavna. Perfect. I have use this term. Uniform subepithelial deposit. See, I ultimately need to differentiate this from PSGN. That also is a subepithelial deposit, right? I have a uniform subepithelial deposit. That's what causes this. Fine. Again, the problem is simple. Okay. You can definitely write about that complication of RPGN. There's a possibility here. The complication of FSGS, there's a possibility here always. Fine. Okay. Again, we have completed almost everything required for you in a page. Etiopathogenesis, elaborate it if it's a long answer, cut it short if it's a short answer. Just because you know a question, don't write lots of that in a short answer. Fine. Okay. Primary, secondary, we know the pathogenesis. Clinical features nephrotic syndrome. 85% of this nephrotic syndrome. Some of them is nephritic syndrome as well. And you have a microscopic thick capillary loop. Sorry, boss, I'm removing you. Okay. And you have immunofluorescence, electron microscopy, and the pathogenesis, and your management. Fine. Okay. Can we do the next one? You guys are going to help me with it. I know you know the routine, right? This is how simply you can do it, right? See, if you have, I'll share the empty PDF also in the Telegram group. If you're good in writing, write in your own words. Do this 7 PDF the day before the exam. Some for general pathology, some for systemic pathology. We should have the template. You should be able to write it easily. Fine. Okay, let's go to RPGN. Etiopathogenesis. What do you think is the etiopathogenesis? It is rupture of GBM, right? It always starts with the rupture of GBM, right? After rupture of GBM, what happens? You'll have irritation of the Bowman's membrane by the fibrin clot, because you'll have obviously the fibrin clot there. Because of the irritation of Bowman's membrane by the fibrin clot, it will result in, you guys have to comment, it will result in crescent formation. If you want, write here what is a crescent formation, or if you want, you can write what is a crescent formation even in the light microscopy, because light microscopy ultimately I'm gonna crescents only, right? It is the crescent formation which will compress the glomeruli. Once it compresses the glomeruli, it's going to cause an acute renal failure. Fine. Elaborate it if you want. What does irritation mean? How does it irritate? What all components will come in the crescent? Write it. How fast it is. It will be rapid by default, because from the rupture to the acute renal failure, I might have 24 to 48 hours of time. The time is very, very important. It has to be fast for me to call it a rapidly progressive glomerulonephritis. Okay. Great. Perfect. Fine. Great. So clinical features, the most important thing is sudden and rapid onset is important. It presents as an acute renal failure. Yes, you might have a little bit of nephritic features as well, hematuria as well, but it presents as an acute renal failure. Whenever it presents as an acute renal failure or acute kidney injury, you always can add on to the features. In the lab findings, I'll have elevated blood urea nitrogen and I'll have elevated creatinine, right? It's rapid onset. It'll automatically become faster and faster, and the progression time is very, very important, right? Microscopy, the first and the only finding I'm interested is crescent formation. Here you can write what is predominantly crescent made of. Anyone? Rishank, we had a very good discussion about GFR and creatinine. Creatinine will be altered in both acute and chronic. GFR also will be altered in both acute and chronic, but what I'm going to rely on is creatinine for acute and GFR for chronic. Fine. Okay. Crescent, perfect. It's an extracapillary proliferation. That is one, which is there in the Bowman space, and it's made of your parietal epithelial cell predominantly. It's made of your WBCs. It's made of fibrin. It's made of little bit of visceral epithelial cells as well. Fine. This is what crescent is. Again, if you want to draw a crescent, you need not be artistic about it, right? Glomerulus, crescent. Put the capillaries here to understand it's a capillary, and you can just draw cells here. If you want to do a different color. Ultimately, they have to understand, what's a crescent and why it is called as a crescent, right? You can put, okay, that's our crescent presents. Simple diagrams. You need not take eosin hematoxin. Take a blue color and a pink color sketch. That's the Luxor pens. That's more than enough, because eosin hematoxin breaks. You're going to waste time, and it will not be much impressive as well, right? Use them and you write it, right? Immunofluorescence. Here I don't have linear or granular. This is where I want you to write the table. Wherever there's a table, please take a scale and a pencil. If you are great in drawing tables, great. But otherwise, please take a scale and a pencil. Fine. Okay. Write it, because it becomes much neat. Even if your handwriting is not good, it at least will be legible, right? We have type 1 RPGN, we have type 2 RPGN, we have type 3 RPGN. In type 1 RPGN, it is linear positivity. In type 2, it is granular positivity or your mesangial positivity. Type 3 is posse-immune. What is linear positivity? We know already, it is Goodpasture syndrome, right? Goodpasture syndrome is your linear positivity. Okay, and here the rest everything you can write PSGN, you can write MGN, you can write MPGN. What's the only disease you won't write in case of an SLE or lupus? What's the only disease you won't write for RPGN? Please never write minimal chain disease, because minimal chain disease gets cured, right? And posse-immune, you write vaginous, vasculitis, and microscopic polyangiitis. Okay, RPGN can be a potential long answer because there are lots of them to write, right? Goodpasture is type 1, granular and mesangial. IgA nephropathy also sits here, right? And we have your vasculitis in the posse-immune characters, right? Perfect. Electron microscopy, the same thing what we saw in the light as the pathogenesis, break in glomerular basement membrane. Management and complication, it's an acute renal failure. The only management is immediate hemodialysis. Because the kidney is failing, I have to change the kidney, wait for the kidney to become normal, immediate hemodialysis, and symptomatic. You need not explain what is symptomatic management. That's not expected out of you now. We'll expect you when you come to final year of MBBS, right? But dialysis is the term. At least that I want to do, because the kidney is failed. I need to change the kidney and use a machine to do that. In between, if the kidney heals, great. If the kidney is not going to recover, the only option for me is renal transplantation. Fine. Is that clear? Okay. Perfect. This entire thing I want you guys to fill. I filled so many template sheets for you. You guys have to fill about this. What is this? Etiopathogenesis. This one etiopathogenesis, we don't know nothing about much about the pathogenesis here, right? Etiology could be a simple viral infection, viral URI. It could be vaccines. It could be drugs. It could be even your Hodgkin's lymphoma. We don't know what happens, but ultimately what happens is there's a destruction of or damage of podocytes. They are under a spectrum called as podocytopathy. Since some damage happens, destruction of podocytes is the outcome, right? Perfect. Nephrotic syndrome. But here, like Devansh said, the most important thing is please highlight here It's seen predominantly in children. There are very few places where age and gender is important for me. Wherever age and gender is important, I want you to write the age and gender. Because if I miss that point, then the entire clue is gone, right? Child with puffiness of face, urine examination showing massive selective proteinuria with albuminuria, it has to be a minimal chain disease. There's no doubt about that, right? And microscopy, what do you write? Microscopy, you should have 2 points here, not one. Both of the point is important for me. Normal glomerulus. Okay. See, whenever I said clinical features, I'm not repeating it, but whatever we saw on the table, write everything here because everything fits here, right? Srimati, it's not normal light microscopy, it is normal glomeruli. Both are very different terms. It's normal glomeruli. The second important point is also there for me. I will have resorption droplets of lipid in the PCT. What is the term given for that? Perfect. We call it lipoid nephrosis. Right? It's lipoid nephrosis. Resorption droplets in the PCT has to be there here because that's the only thing I see in the light microscopy, right? I don't see anything in the light microscopy. It's resorption droplets in the in the PCT that's required, right? Okay. Yeah, it's a classical example of nephrotic syndrome. You're right. Okay. Just a second. Okay, perfect. Immunofluorescence. They are negative for immunofluorescence, which means entire thing will be black. It's not a primarily immune mediated pathogenesis, right? Electron microscopy. Here I'll have effaced food process. See, if you feel that it's worth it, draw a diagram for electron microscopy because I don't have a light microscopic image here. I cannot draw a light microscopic image because it's normal. And it's very difficult to draw lipid droplets in the PCT. So electron microscopy makes sense. Again, see, these are very simple line diagrams, right? I can easily draw an electron microscopy diagram because I know what's going to happen. And this is normal. From here, it becomes flattened or effaced. You can easily draw what's happened here. You can mark this as effaced food process. See, it's not about making the paper more beautiful. It's about making the paper more meaningful. Because this will convey lots than this entire headings. Effaced food process. Okay, the kid knows it. Crescent formation in the image, the kid knows it. That's all is required, right? So automatically, if you are good in drawing, you get to 10, you get more marks. Unfortunately, handwriting does matter, but we can overcome that by having a very neat and a legible presentation, right? Management, you know, it's steroids. Steroids, you will have close to 100% recovery, or you can write close to 99% recovery will be there with steroids. A few things which are steroid resistant, let's not go into that now. When you go to pediatrics, you'll write different types of steroid resistant nephrotic syndrome. Fine. Okay. Let's go to the next disease. Any of this question can come as a long note. Any of this question can come as a short note as well. Short note is enough. If it's an essay question, elaborate it a little bit more. Fine. Etiopathogens of IgA nephropathy. Anyone? IgA, again, I have two things, primary and secondary IgA. Primary is an abnormal IgA molecule. You have an abnormal IgA1 or an IgA, whatever you want, right? Write IgA1 or IgA. Secondary is due to liver failure, because if you want, you can write below, normally liver takes care of it. Shrunk, the complement will not be that much active in case of a membranous glomerulonephritis because it's destroying the phospholipase A2 receptor. Phospholipase A2 receptor is required for my arachidonic acid pathway. Right? That's why the damage is not very extensive. So it's predominantly nephrotic, but in 15% of the cases it can be nephritic also. You'll read that when you come to medicine. Fine. Okay. So abnormal IgA1 or a failed liver, which you can write cannot remove excess IgA. Because I'm telling why it is also causing, right? So ultimately, because of this, there's going to be an excess IgA1 or IgA, which will get deposited in the mesangium If it's a long note, write in detail. Because of the physical and chemical property of IgA, it gets deposited in the mesangium. It's going to elicit inflammation, or in other words, it will activate alternate complement pathway, because IgA can alternate complement pathway. Then I'm going to have inflammation in the mesangium, more cells and WBC in the mesangium, which is going to cause the renal damage. Okay. So it's a clear-cut case of nephritic syndrome, right? One important thing with respect to IgA nephropathy is this word, recurrence. A recurrent hematuria with respect to your diseases in the glomerulonephritis, it's a clue to say it's IgA, because here we missed one thing. It's mucosal inflammation. Any mucosal inflammation whichever increases IgA is going to cause a problem, right? So it could be an URI, UTI, diarrhea, any mucosa. Since mucosal inflammation can come again and again in the same individual, this will be recurrent always, right? So recurrent nephritic syndrome such of IgA nephropathy most often, right? If you want to add on few brownie points, write your other name as well. If you don't know, yeah, it won't have the lag time. Add that also. If you don't know the other name properly, ignore it. Again, writing a wrong name is inviting for trouble than not writing a name. If you don't know, ignore it. IgA nephropathy is more than enough. If you know, write Burgess disease as well, right? And there'll be from the site of infarction to hematuria, mention this, there'll be no lag time. You won't have a lag time here because it's an immediate thing, right? So microscopy is simple. I'm going to have mesangial expansion and mesangial hypercellularity, or you can use the mesangial widening and mesangial hypercellularity. Okay, you can draw beautiful diagrams for mesangial expansion also, but keep in mind when you're drawing about mesangium, make the diagram a little bit bigger so it's easy to appreciate them, because capillary is easy to appreciate normally also, but mesangium is a bit difficult to appreciate when it's normally, right? So draw capillaries here and make sure you draw the pink color in between and blue cells to mention what is the amount of your nucleus will be then a normal mesangium. You need not be like exactly accurate, this many will be, but I can easily compare. Okay, it's going to become more an expanded mesangium with many cells. That tells me, okay, there is hypercellularity. At the same time, I'm also having mesangial expansion, fine. It's recurrent hematuria only, Rishabh, fine. Don't worry about that, fine. Okay, you have mesangial expansion and mesangial hypercellularity. Always write this, normal IgA nephropathy. See, this gives you a clarity that you know what happens normally and also you know what happens when there's a disease. Okay, the central line is to tell this side is normal, this side is IgA nephropathy. This side is normal, this side is PSGN, right? See, because if I know, okay, this is normal, this MGN, I'm telling to the examiner, I'm comparing in that same slide. I know also normal, I also know what happens when it's abnormal. That's the reason I put normal and abnormal. So it's more, see, diagram should tell the story. Diagrams are not to make it beautiful. If diagram can convey things that you know stuff, that should be more than enough, fine? It's nephritic syndrome, okay? Fine. Okay, FSGS, I'll have an IgA deposit exactly in the mesangium. Fine. Electron microscopy, again you'll have electron dense deposits in the mesangium. IgA nephropathy management is always supportive management. You'll take care of it whenever there's a renal failure, take care of that, right? The most important thing is IgA nephropathy follows important because it is recurrent. Can I have more of chronic kidney disease? There is, right? So the recurrence increases the risk of CKD and eventually the risk of transplant. Because that's the outcome of any patient with IgA nephropathy. They are going to go bad over the period of time. And you cannot stop that from happening, fine? Okay, got it. Fine. Simple way to present. Please make sure you are more legible. If you are not good, write slowly. When you are going to write points, you need not spend much time. If you write paragraphs, you might spend much time. Just points, that should be more than enough. Flowcharts are more than enough, right? Okay, let's go to FSGS. So how do you classify FSGS? How do you classify the etiopathogens of FSGS? Just give me a second, guys. Okay, so FSGS, we classify them into FSGS as primary FSGS and we have secondary FSGS, right? So primary FSGS is due to genetic abnormalities here. So you can write them, they are congenital nephrotic syndrome. Write not everything, write 2 points, that should be more than enough, fine? Okay, type 1, type 2, ApoL1, that's great. But if you can just write congenital nephrotic syndrome type 1, the nephrin mutation, the nephrotic syndrome type 2, the podosin mutation, that should be more than enough. If you want ApoL1, great. Secondary, any glomerulonephritis can become, diabetes can become, hypertensive can become, right? At the same time, you might also have problems with your ablation. Renal ablation, FSGS also is possible, fine? So I have the why it is happening. Yeah, what are the different types of FSGS etiology wise? Pathogenesis wise, whatever happens when it's chronic, your FSGS is a type of podocytopathy. Fine, once the podocyte is getting destroyed, recurrent damage to the podocyte will cause a healing mechanism because podocyte is on the mesangial surface. It will cause more and more and more healing mechanism. So recurrence, obviously more healing, more fibrosis, which ends up in having FSGS, fine? So repeated damage or repeated, please use this term, podocyte injury. Okay, it will actually start with a podocyte injury only, will cause more and more healing, and when it heals, healing induced scars will be there. That over the period of time will cause focal segmental glomerulosclerosis. Right? Yes, obviously, Pranjal. Okay. So clinical features, nephrotic and chronic renal failure. You can write whatever features of chronic renal failure you know, including GFR shunt, also creatinine, also blood urine nitrogen, and it has to be a pure it's a with respect to nephrotic, it's a nephrotic syndrome, right? And this is the most common cause of nephrotic syndrome in adults. It's rare in children. If it's a child, I always think of an inherited cause of an FSGS, fine? Microscopy, here is where I want you to mention what is F and S means. Focal and segmental lesions. You'll have focal fibrosis and segmental fibrosis, right? So here, if possible, draw 2 diagrams because I have to explain what is focal as well as what is segmental. If I put a single glomerulus, I can explain segmental, right? So if I have, let's draw like this, write this as a true cut biopsy. Biopsies are always termed as true cut biopsies. In this true cut biopsy, you can draw diagrams of 3-4 glomeruli. And here, this is, you can write focal lesion. It's focal, not all of them are involved, right? And then put a single glomeruli with good amount of your capillary and shade this dark and write segmental. So again, it explains what do I mean by focal and what do I mean by segmental. It's a focal segmental glomerulosclerosis. Fibrosis focally and segmentally, that's all, fine. Immunofluorescence, it's actually based on the etiology. Based on etiology, it will differ. If it's diabetes mellitus, I won't have immunofluorescence, but if it's in primary, I won't have immunofluorescence, but it's an lupus causing it, I will have immunofluorescence by default, right? So it's based on the etiology. You not mention about that much, fine. Electron microscopy, again, you might not go to electron microscopy here because if I diagnose FSGS, I obviously going to go for treatment, fine. No, see, Rishankar, This is just for our exam to go through it. So hyalinosis, anything going to be pink in color, anything will have a little bit of deposit of proteins, I'm going to use the term hyalinosis. Fine. Okay. I can have focal IgM, C3 as well, like Srimati said, but again, it's primarily based on the etiology. You can write, or if you want to elaborate in a long answer, you can say, okay, lupus will have this, your MGN will have this, IgA nephropathy will have this. Fine. Okay. Electron microscopy, again, it's based on the etiology. If it's a long answer, try to elaborate it. Finally, what I'm going to see is I might not see deposits, I might see fibrotic foci. That's all. Management, it is dialysis or renal transplant, because FSGS is a terminal stage. The kidney is not functioning. Based on the degree of damage, I'm going to replace the entire kidney with the help of dialysis or with the help of a renal transplant. Fine. Okay. That will sum up almost every glomerular nephritis, what we want to discuss about, right? Just one slide for every glomerular nephritis. We have just compiled the information what you already know and present it in a way which is required for exam. We'll do the same thing for almost every system, right? ATN. Just a few words about ATN, because we already know quite a few things about ATN. I want you guys to tell how do we classify ATN. What are the different types of ATN you know? I'm sure you know the different types of ATN, right? What are the types of ATN you know? There are two types of ATN, which is ischemic ATN and your toxic ATN, right? So we have toxic ATN and we have ischemic ATN, or I can call it pre-renal ATN also. If you want, you can add additional points for what does pre-renal mean if it's a long answer. Otherwise, just stick to pre-renal ATN. That should be more than enough for us, right? So can anyone name me at least one toxin which can cause ATN? We have read quite a few toxins which can cause ATN. Any one toxin which can cause an acute tubular necrosis? Anyone? Any one toxin? Can at least start with simple things. Can have drugs, since you know pharmacology. The aminoglycosides, there are lots of aminoglycosides which can cause ATN. You can write that. Perfect. Gentamicin. Rishank, doubts? I've explained you already in detail about FSGS. See, if the podocytes is damaged, obviously it will present as nephrotic syndrome, right? Okay, you can add crush injury. You can add ethylene glycol. One of the most important thing which causes ATN, I want you to write along with the drugs, because that also is iatrogenic, which is contrast agents. The contrast CT, contrast MRI, any contrast I do, which has a obviously a predisposition to cause a nephrotoxic injury, right? So ischemic I have, nephrotoxic I have, right? So predominant of the pathogenesis will be directed against ischemic, because ischemic is the biggest cause, right? And toxic ATN, one of the important thing, ischemic ATN will always be patchy. Toxic ATN will be continuous. Fine. So when you go to the pathogenesis, I'm going to go predominantly with respect to ischemic ATN, right? Less blood supply. So two things happens. I'll have tubular injury. Primarily proximal convoluted tubule, the microvilli will be destroyed, right? So tubular injury. At the same time, the less blood supply will also trigger your, increase your RAAS system, which will cause vasoconstriction, which will again add on to the tubular injury, right? So once you have injured tubules, there'll be sloughed off cells, right? So the cells will block the lumen. The sloughed off cells will block the lumen, which might cause a renal shutdown, or in other terms, oliguria. Okay, that's the reason for, primary reason for an acute kidney injury. Obviously, I'll have interstitial inflammation plus this vasoconstriction along with the inflammation will obviously reduce the GFR. So I'll have reduced GFR, I'll have reduced urine output, I'm going to have an acute renal injury, fine. Physician, it will be there in your Telegram group. The link is there in the pinned comments, fine. Okay, perfect. So it's again most likely will be in a short note, so this much is enough. If it's a long note, you can talk about the tubuloglomerular feedback, you can talk about the renin-angiotensin feedback. That will actually compound the entire problem, right? If it's a toxic ATN, the only thing is toxin can directly cause tubular injury. That's the only difference here. Toxin causing tubular injury as opposed to vasoconstriction causing tubular injury. Clinical feature of an acute renal failure. Microscopy, what I'll have? One, I'll have coagulative necrosis of the tubules. Again, if it's a long answer, write what is coagulative necrosis of the tubules. The pink color, there'll be no nuclear features, there'll be ghost-like tubules, which is retained architecture, everything can write, right? Second, you can have the sloughed cells in the lumen. That will be there in the microscopy. Third, I can have obviously any time it will be a minimum amount of interstitial inflammation. Though it's not important, but that will be there. The same time, with respect to an acute tubular injury, I want you to also write urine examination. Because here urine examination is an important thing. I'll have one very unique finding question. What type of cast you will see in case of a tubular ATN, in case of ischemic or a nephrotoxic ATN? What will be the type of cast? You have muddy brown cast. The muddy brown cast is due to lipofussion. The lipofussion of the sloughed cell will actually come out in the urine, which will form a muddy brown cast. That's a classical finding in case of an acute tubular injury or an acute kidney injury. Fine. Okay. Management, again, it's based on the etiology, but the primary management is fluid replacements, because the most of the predominant thing here is pre-renal, right? Fluid and electrolyte management is more important. Based on what stage it is, based on that, I'll have to give the fluid or the electrolyte so that we can make the patient come back to normal. Fine. Perfect. Great. Right. So ATN, if it comes, don't get stumped, because we have read lots and lots about glomerular nephritis, but we are not concentrating much on ATN, but ATN also is required. Fine. Glad you like it, Natasha. Fine. Let's go to the last but one part of renal tumors, right? Renal tumors, most often it might come as an LAQ, because there's multiple parts in a renal tumor I can ask. Because if we ask glomerular nephritis, it's very short. Renal tumors, there's etiology. Every etiology starts with risk factors, sporadic, syndromic, clinical features, multiple subtypes. Most of the cancers, there's a possibility for them to come to an LAQ. So we know the format of the LAQ first half. Second half, you can write like this, fine? Obviously, first, if it's a long answer, expand the clinical features, the initiation phase, the maintenance phase, the recovery phase, fine? Okay, perfect. So since you are in renal tumors, I've written something about the syndromes. I want you guys to tell me what could be the sporadic risk factors. Anyone? Sporadic risk factors of renal cell carcinoma primarily. Let's not go to benign tumors. Sporadic risk factors, the most important thing, even in the long answer question we saw, was smoking. Smoking is one of the important risk factor. Then in your in general pathology chapter, we must read about aniline dyes, which is there in painters, can increase the risk of it. Obesity and unopposed estrogen. Obesity is a pro-inflammatory state which increases the risk of many cancers, including your renal cell carcinomas, right? And also asbestos. Asbestos, one of the extra lung pulmonary manifestations is going to be a renal cell carcinoma it can cause. And when we know, if you read about cystic disorder and acquired cyst, not ADPKD, ARPKD, acquired cyst can increase the risk of your papillary renal cell carcinoma. Fine. Yes, most likely, see, because the primary thing of most of the pathology is hematopathology or oncopathology. So oncology dependence in pathology is a little bit more, not just in pathology. When you go to medicine surgery also, there will be predominantly tumors which will be covered. Fine. So we know syndromes. Again, syndromes, if it's a long answer, try to explain what are the components. Short answer, just the name should be enough, right? Von Hippel-Lindau syndrome, I'm sure you know the gene, VHL gene, which is there in chromosome 3. Okay. Clear cell renal cell carcinoma, cerebellar hemangioblastomas are the other tumors. Fine. Okay. So hereditary leiomyomatosis and your renal cell carcinoma syndrome, it's there in the name. What all happen? Leiomyomas and renal cell carcinomas. That's very, very simple, right? And this is actually papillary RCC, and along with that, leiomyomas. Multiple leiomyomas. That's leiomyomatosis, right? And the mutation is in FH or fumarate hydratase. Okay. Hereditary papillary carcinoma. As the name says, it's going to have papillary renal cell carcinoma, and the mutation is in met proto-oncogene. Birt-Hogg-Dubé syndrome. The one good thing is the name BHD. That's a gene. BHD gene. It codes for a protein called as folliculin. Actually, this folliculin, if you remember, it helps me in such a way. One is renal cell carcinoma, other is follicles, skin tumors, right? So the hair follicles, I'll have skin tumors primarily coming from the hair follicles, plus any type of an RCC, I'll have them, right? If you are good in general pathology, okay, that's good, Rishan, right? That's the ultimate motive. If you can forget something, if you can make a logical story out of it, my job as a teacher is done. You're able to think, right? If you can think, university exam is useless. You can do wonders about it, right? If you know about general pathology, neoplasia chapter, all of these guys are autosomal dominant. Almost every cancer syndrome is autosomal dominant. Almost every cancer syndrome happens from tumor suppressor genes. Converting a short answer to essay is not difficult at all, right? If it's a long answer, one Hippolindo, VHL gene, tumor suppressor gene. If you want to elaborate more, Knudsen's 2-hit hypothesis, fine? Okay. That's good, no? Even before giving the paper, if you're comfortable or you're passed, you're in a good track stage. It's fine. Okay. Clinical features. Clinical features will start with elderly. See, if it's a long answer, don't worry about the clinical features. Look at the question. Whatever they have write it here. The triad, right? Triad of mass, hematuria, and pain. Mostly will not be there in all of them, but generally this is the triad, right? That should be enough, right? Since we are in the last, I'm just compiling everything here so that it's easy. I'll put here both because there's always a confusion where it comes from. I told in the class why there's a confusion also. It's PCT as well as DCT. Robbins goes to distal, go with distal, right? Mutation in VHL, mutation in your MET proto-oncogene. Here might have hyperploidy. Okay. This is TP53. That's one of the worst prognosis. So always worst prognosis, put TP53, right? These two might be new informations. If you want, don't write, fine? Okay. See, ultimate test for all of you guys is not in the college. I always trust that your test begins once you complete MBBS and then there's a patient sitting in front of you. No bit, no FARRE, no one to help, direct exam, right? That's the real test. And I hope you guys will ace all that, fine? Okay. Most commonly in the upper pole of the kidney, variegated appearance. Yellowish in color because of the fat plus hemorrhage because of lots of microscopy. Papillary, multifocal. Multifocality is the most important thing for papillary RCC, right? Chromophobe, it's more or less well defined. I'm not saying capsulated. It's a well defined lesion with a central scar. There's a term called as mahogany brown color. You can write that, fine? Okay. Collecting Bellini RCC, it's something which is very sclerotic mass and it's very infiltrative mass. Okay. Collecting generally we don't read much about the microscopy because not much required for us, right? Because very like 5% of them are collecting RCC, right? Microscopy, it's clear cells and capillaries. Abundant of capillaries and clear cells, is that's how it will be. Again, if you're good in drawing diagrams, draw diagrams, right? If you're drawing a tumor, microscopy for anything, put a square or a circle if you have circles with you, because that's how microscopic field looks like, right? Yes, Manish, give me a second. Draw adipocytes and blood vessels. That's all, right? Simple things. Microscopy of this, whenever it's papillae, and we have psammoma body. Whenever you have papillae, obviously you'll have to end up with having psammoma body, right? Perfect. Chromophobe, they are cells with increased pink cytoplasm. Chromophobe, generally most of the cancer will have high NC ratio. Here it will not, right? Abundant pink cytoplasm, and the most important thing is you'll have a classical perinuclear halo. Fine. Then obviously here I'll have collecting ducts and excess amount of desmoplasia. Actually, it's a very desmoplastic thing, plus ducts with highly pleomorphic cells. Okay, fine. See, there is a video of patterns of neoplasia. See that the day before the exam. It will give you an overall view of what all, because anyway in your paper cancers will be there. You cannot help it. Patterns of neoplasia will tell you what to do for microscopy of cancer. 4 fits of neoplasia plus pattern can fit in for almost every cancer, right? Be day before the exam, watch that so that it will come in handy. Fine, perfect. Atypical hobnail is amazing, right? If you want to score extra, have XP11 translocation associated RCC, not the general ones, rare new ones, happens in adolescence. That's a very important clue. TFE3 gene, and in microscopy, you'll have both clear cell and papillae. The last but not least, just one word about it, medullary RCC. Which disease increase the risk of medullary RCC? Anyone? There's only one disease which increases the risk of medullary RCC. That's your sickle cell anemia. Just write that, that's more than enough. Increase in risk in sickle cell patients. Okay, these are just extra points. If you want to score more, want to be a topper, write these things. But if you're looking for PPPP, this 4 should be actually more than enough, right? So renal tumors, if it comes in a long answer, if they ask about the types, write them elaborately, right? Wilms, I won't call it as an RCC because since you're talking about RCC, I didn't put Wilms. Wilms can come as a renal tumor if it's a childhood renal tumor. See, because most of the cancers will be a long answer note. 50-year-old having smoker and pain, I won't write Wilms. Don't write Wilms, fine? If it's a 5-year-old kid having a renal mass, write Wilms. If it's the oncocytoma as a benign tumor, it's not a cancer. If it's a renal cell carcinoma, these are the only 4 variants of renal cell carcinoma. Cytoma is a benign tumor, fine? Same way as your chromophobe RCC, intercalated cells of collecting duct, well-defined central scar, but you don't have the perinuclear halo, that's all. Fine? Okay? Okay. Last one about cystic kidney disease, right? Cystic kidney disease, I don't know if they'll ask in a long answer. If I am the examiner, I'll keep cystic kidney disease for the practicals because anyway, all of your hospital have at least one polycystic kidney disease sample, right? So ADPKD or ARPKD is going to most of the time come in that, right? So etiopathogenesis, most of them are altered your ciliary function, right? Okay, Rishank, I won't use the term RCC of infancy. It's a renal cancer, right? Renal cell carcinoma has a different etiology. Wilms has a different etiology in the origin, right? I call it as Wilms tumor. I don't call it a renal cell carcinoma of the infancy. It's a malignant tumor seen in the kidney in children. That will be a better terminology than using as RCC for children, right? Okay. So if they ask in a short answer or long answer, the first thing is it has to be an altered ciliary function. Be it ADPKD, be it ARPKD, be it whatever cystic kidney disease is, it's the same as the altered ciliary function. There's a beautiful flowchart in Robbins, right? So it can be mutation in whatever protein it is. Polycystin 1 and 2, if it's ADPKD, fibrocystin, if it's ARPKD, both of them are ciliary proteins only. Almost every polycystic kidney disease, they are ciliary protein mutations only. Fine? Okay, perfect. So here, 11, because of this, I'm going to have altered mechanosensation of the tubula, right? Or altered polarity because of the altered mechanosensation. Because mechanosensation is the one which helps me to identify the polarity. This alters the polarity of the tubular epithelial cells. Okay. And also mutation will alter the calcium flux. The calcium flux alteration will actually result in more fluid secretion. This results in more fluid The altered polarity of the tubular epithelial cells results in abnormal proliferation of cells and extracellular matrix, right? Because of this, I have more cell division and more matrix production. More matrix production make it a little bit firmer. More cell division and fluid accumulation results in the cyst in the kidney. Okay, this is the pathogenesis for ADPKD, ARPKD, nephrotic, whatever it comes. Fine, that's all. Same thing. So you can just write, if it's ADPKD, write this alone. If it's ARPKD, write this alone. But mechanism is going to be one and the same, right? So what changes is the presentation. What changes is how they look in the microscopy, right? So ADPKD, ARPKD, we have polycystin 1, polycystin 2 mutation, right? So do anyone remember the chromosome? PKD1, PKD2 is the gene. If you remember the chromosome number, great. If you don't remember them, don't commit wrong numbers. It's chromosome 16, chromosome 4 for PKD1 and PKD2, polycystin 1 and polycystin 2. If you know, it's great. If you don't know, ignore it. Fine. Fibrocystin is PKHD1 gene. Okay, that's your fibrocystin protein. PKHD1 gene is seen in chromosome 6. Fine. PKHD1 gene, which is seen in chromosome 6. You need not write 6P, 6Q, that all, right? If you forget, it's completely fine. Srimati 4Q21 is amazing, but I really don't expect. I'll be very honest. I don't know Q21. I know chromosome 4. That's more than that itself is not expected from you. But if you write, it's amazing. Fine. Classical features: large multicystic kidney, liver cyst, berry-aneurysm. This associated finding is very, very, very important, right? Liver cyst and fibrosis, enlarged cystic kidney at birth. Okay. If required and if you have time, write the types. I have perinatal, neonatal, infantile, juvenile, right? I have different types. I have perinatal ARPKD, neonatal ARPKD, infantile ARPKD, and juvenile ARPKD. More age it is juvenile, better prognosis. Worst is perinatal. It's worst prognosis. Fine. Okay. So how do I differentiate them? Diagnosis based on your clinical your ultrasonogram or gross examination only, right? Cyst on outer and cut surface. Draw them. Whenever drawing an outer surface of the kidney, put a ureter, right? So you can mention that it's an uncut kidney. Okay. Whenever you draw the cut surface of the kidney, how do I know it's a cut surface of the kidney? Either write cut surface below or write the pelvic calyceal system. You can't see pelvic calyceal system in a cut outer surface, right? So that's how it helps me to say it's a cut surface, right? Snejith, the polycystin 1 and 2, apart from the renal, they also have an important role in the endothelium and the vasculogenesis. That's why you have berry-aneurysm as well, fine? Okay, here, then right, I have completely replaced by cyst. You can either write it or you can draw the pelvic calyceal system to know it's a cut surface. For a chronic pyelonephritis, when I have to tell a scar, I need to know it's a cut surface, right? Okay, here, again, outer surface will be smooth, no cyst, and here I'll have cyst only in the cut surface. Again, I'm trying to draw the pelvic calyceal system. I'll have elongated cyst in the cortex. That's a very unique finding of ARPKD, and round cyst here, right? Cyst on the cut surface, you'll have elongated cortical cyst. That's very, very classical for ARPKD. Fine. This is a very, very classical finding for ARPKD. Complications, I won't exactly call it a complication. It's like an outcome. ADPKD might have hypertension. It might end up in renal failure. You might have renal calculi. Obviously, the final part is everything is going to go haywire and I'm going to replace the kidney. ARPKD is problematic. The problem is it can cause very early onset renal failure and also it can cause liver failure. ARPKD can be sometimes fatal, especially in the perinatal forms. Fine. Okay, that's about you. ARPKD and ADPKD. Fine. Okay. So what we have done in this is, it's just a compilation of what you have studied in renal pathology, right? So I touched base on almost the important ones. This is for the final day. if you are watching it for the first time, you might not understand things, but you studied for the entire year, there's a very good compilation resource. Use this just for compilation. And what we'll do in every FARRE is we'll start with this. I want you to write this and get used to this, because once you start knowing how to write a long answer question, because that's the first impression, most of you will write with the long answer question only, right? Okay, so we'll start that. How to give a reason, will impress the teacher, and they'll go for it. Fine. Okay, Snehajit, I cannot cover everything. Renal stones, you know the nucleation and the additional factor, right? About hypercalciuria, hyperuricemia, and whatever the different types of stones. There are 4 different variants of stones. Important calcium oxalate. You have the triple phosphate stones. You have the cysteine stones. You have the uric acid stones. These are the 4 important ones. Clinical symptom is obviously your hematuria, could be having recurrent infection, renal angle pain, renal angle tenderness. The way to diagnose is clinical. Microscopy will have the different shape of the calculi. You obviously know the shape of the calculi. And also treatment is lithotripsy, or if it's a tiny one, just you can have increased fluid intake or IV fluids. You can flush out the stone. It's acute pain, give buscopan, which is an antispasmodic agent. Fine. Rishank, you message me as well. When we go to liver, we'll talk about the jaundice. Wilms tumor. See, Wilms tumor, it's a tumor seen in children. It's not a tumor of infancy. It's a tumor which commonly happens around 10 to 15 years of age. It can be syndromic, it can be sporadic. If it's syndromic, we have 3 syndromes: WAGR syndrome, we have Dennis-Drash syndrome, right? And also we have your Beckwith-Wiedemann syndrome. WAGR and Dennis-Drash are WT1 mutation. Beckwith-Wiedemann, W in with and W in Wiedemann, that's a WT2 mutation, right? So WAGR, just give me a second, I'll write them so that it'll be there in the PDF. Okay, so Wilms is the most common malignant tumor seen in children. Please don't use the term infancy. It's not seen in infants, it's seen in children 5 to 15 years of age. Okay, Wilms tumors can be syndromic, can be sporadic as well. Syndromic Wilms are pretty common, and there are few syndromes which I want you to remember. Like I said, I have WAGR syndrome. Fine. So WAGR stands for Wilms and Iridia. Okay. Genitourinary problems and retardation. Okay. So this is in WT1 gene defect. Then I have Dennis-Drash syndrome. Dennis-Drash syndrome, it's Wilms along with gonadal dysgenesis. So these are again clue points to say, okay, this probably could be a Dennis-Drash syndrome, a hermaphrodite. Gonadal dysgenesis is a technical term for abnormal sexual things, right? Okay. Devyansh, Wilms is an histological diagnosis. We don't require immunohistochemistry there, right? Last one is aniridia. Iris will not be there. Okay, aniridia. Okay, we have Beckwith-Wiedemann syndrome, right? Okay, it's 2W, and actually the Wiedemann helps. Vivek, we are going for FARRE. There's a final tool for revision. This is not the teaching part of it, right? This is just to compile for the final part of revision, right? WT2 gene. It's a Wiedemann. So everything becomes bigger, including the orifice. So there's an omphalocele. Omphalocele is where all the contents will come out of the umbilicus. Okay, you'll have hemihypertrophy. Okay, along with that, you'll have Wilms syndrome. Fine. Okay, Fine, that's what Beckwith-Wiedemann is, right? What happens, Wilms syndrome, the presentation of Wilms syndrome will most often be abdomen mass. Because it's children, right? Even if a tiny kidney becomes a little bit increased in size, they can definitely see that. It's an abdomen mass, might cause pain, fine? So Wilms grossly, they are gray tan in color, might have areas of hemorrhage and necrosis, especially in aggressive variants. Okay, and obviously it's a malignancy, so it will be infiltrative. It can go even beyond the capsule. Microscopy of Wilms, most of the Wilms are called as triphasic Wilms. There are three phases in Wilms, most of them. I do have monophasic Wilms also. There's triphasic Wilms. So we have epithelial elements, where you have the tubules. All these are immature. They won't be mature tubules. Immature tubules are epithelial elements, right? We have blastemal elements. Blast is small round blue cells. That's what will be in the blastemal elements. Immature cells. And we have stromal element. Okay. Stromal element will be the normal parenchyma, normal stromal, right? Fine. Not gone into MPGN because it's completely gone, right? Omphalocele, where the umbilicus, the organs will come outside, right? You will read about omphalocele gastrotritis more when you go. It's a congenital abnormality when you go to surgery, fine? Okay, this is a triphasic Wilms. I do have monophasic Wilms where I see only blastemal element also. Generally, it's triphasic Wilms only, right? That should be more than enough for you. Two things in Wilms. Whenever you see anaplasia in Wilms, anaplasias, more than 5% of the tumor having anaplastic cells. When I say anaplastic feature, the pleomorphism, high NC ratio, more than 5%, this indicates TP53 mutation. And obviously, it is a poor prognosis. That's one. Second thing in Wilms is, I told right, Snejit, aniridia means no iris, aniridia. Triphasic means there are three tumors variant. See, most of the tumors, I will say it is epithelial or mesenchymal, right? So it's a primitive cell, so it can deviate into three different things. Let's say, assume I'm having a tumor from the stem cell. Stem cell in my bone marrow can become AML M1 or AML M7. So like that, I have different phases because the tumor arises from a very, very primitive cell. That's why it's a triphasic Wilms. If it's a little bit more mature, I can have epithelial Wilms. I can have blastemal Wilms. It's not differentiated at all, right? Something of that sort, right? Okay. Okay, Snehal, right? And one more thing I want you to add to it. There's something called an, okay, got it. I can have different, see, I won't call exactly it as a teratoma because it's not coming from a totipotent stem cell. It's coming from an immature renal parenchymal cell. That's why it's able to produce only renal parenchymal cells. It's not able to produce others. Fine. Okay. Something called an nephrogenic rest. So nephrogenic rests are seen in the non-tumorous part of the kidney. See, I have a, let's say I have a tumor here. I will see nephrogenic rest here. What does nephrogenic rest means is, it means the patient is having a syndromic Wilms, which means there is more risk of Wilms in the other kidney. Because of syndrome, it can be bilateral, right? Just write about this. That should be enough for Wilms tumor. Okay. Fine. Great. So that will complete our lecture today. See you tomorrow around 7:30. We'll slowly and steadily do it. I hope please compile this, have this PDF at the end of the day before the exam. This will be a short source for you to just recap it, right? Yes, Rishan. That's why it's a Wilms tumor. It's a different origin, right? Okay, see, if I have a syndromic Wilms, not only this part of the tumor is abnormal, the entire kidney is abnormal because it's syndrome. So this has become a tumor. So this will have very minimal abnormality. That we call as a nephrogenic rest. If it's a sporadic Wilms, only this part will be abnormal. It's similar to BRCA gene mutation. BRCA gene, if it's in the tumor, it's sporadic. BRCA gene in the blood is syndromic. So when I have a normal kidney also showing some morphological change, which means entire kidney is a problem, which means it's a syndrome. So the other part of the other kidney also, there's a propensity to get Wilms tumor. Fine. My next lecture is tomorrow, Sunday. Topic I have to say, I think it is, I don't know, wait, I'll see it. I'll update you guys in this Insta. Fine. It's not an elevation, it's a microscopic finding. That's all. Rishank, see, Rishank, MPGN itself, right? It's a place where it's kind of getting dissolved, right? So when I say something is getting dissolved, if I'm saying now MPGN type 2 is nephrotic syndrome, you will definitely find out some books saying that MPGN could be a nephrotic syndrome, right? That's why even if you look at Robbins, the classification is not exactly clear cut, right? It's nephritic for now, keep it there. But when you go to medicine, when you go to nephrology, you'll have multiple other viewpoints. Let's change that when it comes to that, fine? No, bilateral involvement means the other kidney also will have cancer, also will have Wilms tumor in future. Fine. Thank you, Rishan. Tomorrow will be CVs and lung. Okay. See you guys.